Welcome to the Radiology Advances podcast. Today, we're looking at a study that could change how we approach brain imaging, especially for patients with memory loss. In clinical practice, getting high-quality MRIs from older, anxious patients can be a real challenge. Holding still in a loud scanner isn't easy, especially with dementia.
Yeah, even slight movement can ruin the scan, and no one wants to repeat it. It's stressful for everyone.
Exactly. So today we're going to unpack the latest research on deep learning accelerated T1 MPRAGE MRI. This comes straight from a paper in Radiology Advances, authored by Doctors Gill, Tabari, Huang, and colleagues at Mass General Hospital, Harvard Medical School, with collaborators from Siemens. The title is Deep Learning Accelerated T1 MPRAGE MRI for quantification and visual grading of cerebral volume in memory loss patients.
This study asks essentially, can deep learning improve our standard protocols, not just speed things up, but actually maintain or maybe even boost diagnostic quality for these vulnerable patients?
Right. It's not just faster scans, it's about a better patient experience, smoothing out workflow, and maybe getting more accurate longitudinal tracking in neurodegenerative diseases. Okay, let's really get into it. Right now, evaluating memory loss heavily relies on high-resolution 3D T1-weighted imaging, volumetric assessments.
That's right. The workhorse sequence is typically MPRAGE or magnetization-prepared rapid gradient echo. It gives us that detailed brain anatomy absolutely essential for looking at structure, spotting atrophy.
And that high resolution is key, isn't it?
Oh, totally, for two main reasons. First, for radiologists doing the qualitative visual assessment spotting those subtle signs of brain atrophy. And second, it's fundamental for the quantitative stuff, the volumetric measurements. Those are vital for research in neurodegenerative disease, and increasingly in the clinic too for tracking progression.
But there's a catch with the standard MPRAGE. The big limitation is
Yeah, time. It takes a while.
exactly long acquisition times. We're talking several minutes.
Which for patients being evaluated for memory loss, maybe they can't stay perfectly still. That's a problem. And those artifacts mess with image quality, which then impacts diagnostic reliability. It's a real bottleneck, can lead to repeat scans, less certain diagnoses.
It's more than just an inconvenience. So long scans, especially for this group, are a major pain point. How do we get that critical high-res data faster without the ordeal?
Well, that's where the deep learning comes in. Enter Deep Learning Accelerated MPRAGE.
It's pretty impressive, actually. First off, it can achieve up to 0.5 millimeter isotropic resolution.
Wow. Okay. That's double the detail compared to the standard 1.0 millimeter.
Precisely. And it does this with a clever two-step deep learning reconstruction. First, there's an unrolled variational network. Think of it like getting a really good initial sketch from limited data. Then a second DL layer does super resolution. It takes that sketch and sharpens it to that superfine 0.5 millimeter target resolution. And for the acceleration, it uses a technique called Chi-Purina.
Different from the grappa used in standard MPRAGE.
Right. They both speed things up using parallel imaging, collecting less data and filling in the gaps in MRI K-space intelligently. Grappa learns relationships in the acquired data and tries to use these to fill in missing K-space lines. Chi-Purina, though, strategically samples K-space using more complex patterns. This often allows for even greater acceleration, especially in 3D scans.
Got it. So a more aggressive acceleration strategy. So with this tech, what was the study actually trying to prove? What was the hypothesis?
The core hypothesis was that this new DLMP range would be essentially equivalent to the standard MP range for measuring brain structures. That's the morphometric analysis. And critically, that it would be non-inferior in the qualitative assessment or how the images look to a radiologist.
How do they test it?
They ran a prospective study at Mass General Single Center. They recruited 64 participants, average age around 62, about 45% women, and crucially, all were patients undergoing evaluation for memory loss on 3T scanners, so the right patient group.
And importantly, each patient got both scans, right? The DL and the standard.
Yes, exactly, and in the same session. That head-to-head comparison patient as their own control is a real strength that minimizes variability.
Okay. And how did they measure the results?
Quantitatively, they looked at the absolute symmetrized percent change, ASPC in cortical volume and thickness. They used the free surfer algorithm, which many people doing neuroimaging research will know, across 11 brain regions for volume, 6 for thickness, and they used Bland-Altman analysis too to really dig into the agreement between the two sequences and check for bias. Two experienced radiologists, blinded to which sequence was which, rated image quality. They looked at artifacts, sharpness, gray-white matter differentiation, overall quality using standardized scales, and they also rated regional cortical volume loss in 6 key areas. Again, blinded.
Okay, let's get to the results. What's the big headline for clinical practice?
Speed, without a doubt. DL MPRAGE took 2 minutes and 11 seconds compared to standard MPRAGE at 5 minutes 21 seconds.
Less than half the term?
Exactly. And that shaved 15% off the entire memory loss protocol time.
15%? That's huge for workflow in a busy department. More patients, shorter waits.
And think about the patient. Less time holding still, less anxiety, especially for that longest part of the scan. Big difference.
Okay, speed is impressive. What about the actual measurements, the quantitative stuff? Were they the same?
Interestingly, no, not exactly the same. The mean regional volumes were actually systematically lower with DLMP-RAGE in several areas.
Lower. Like, how much lower? That might sound concerning initially.
You might think so, but here's the crucial part. They looked at the percent difference, that ASPC value, and those differences were consistently small, averaged only 2.8% across regions. The max was about 4.8% for the cingulate gyrus.
Okay, 2.8% average difference. How does that compare?
It aligns really well with what we already know about the reproducibility limits of FreeSurfer itself. If you scan the same person twice with the standard method, you'll get small variations like that anyway.
Ah, I see. So the differences they found are within the expected noise of the measurement tool itself.
Pretty much, yes. Which means for tracking changes over time in a patient, these small absolute differences arguably aren't clinically significant.
That makes sense.
And the Bland-Altman plots confirmed high agreement overall for volume and thickness.
This suggests they're generally interchangeable despite those small systematic shifts. That's an important finding.
Definitely. So quantitatively equivalent for practical purposes. What about the qualitative side? How did the images look to the radiologists?
Really good news there too. DLMP-RAGE was rated as non-inferior to the standard across all the quality metrics, sharpness, artifacts, gray-white differentiation, overall quality, all statistically significantly non-inferior.
So at least as good.
At least as good in the radiologist assessment. And importantly, it was equivalent for assessing regional cortical volume loss. No difference in how they rated atrophy.
And did the radiologists agree with each other?
Very strong agreement. Near perfect for overall quality and gray-white differentiation, with kappa values around 0.9. That's solid.
Are there any sort of downsides or nuances we need to be aware of?
Well, nothing's perfect. The radiologist did note a slight tendency for Gibbs ringing artifacts.
They saw it slightly more with the DL sequence. Phantom scans confirmed it too. It didn't impact the overall non-inferiority rating in this study, but it's something radiologists need to be aware of, especially if looking closely at structures right up against the bone.
Good to know. And you mentioned earlier some previous DL studies found superior subjective quality, but this one only found non-inferiority. Any thoughts on why?
Yeah, that's interesting. A few possibilities. Maybe the specific DL reconstruction used here working from unfiltered K-space introduces some subtle artifacts like that Gibbs ringing, whereas methods working on the image domain might avoid them, or it could be the scanner field strength. This was done on 3T scanners which already have high baseline image quality. Maybe the improvements from DL are just less obvious to the eye compared to studies on 1.5T systems.
Right, the baseline is already so good. And the authors pointed out limitations too, right?
Yup, it was a single-center study, so needs external validation. They mentioned the sample size, which could always be larger, and they only use FreeSurfer for volumetrics. Other software might give slightly different absolute numbers, though relative changes should be similar.
So clear paths for future research there. For someone maybe starting out, those are good avenues to explore.
Absolutely.
So let's connect this back. The big takeaway seems to be this significant time saving, more than cutting the MPRAGE time in half with essentially equivalent results. What does that mean for day-to-day practice and patient care?
It means huge efficiency gains, better scheduling, reduced wait times. But critically, it's about the patient experience. Think about serial scanning. Patients needing regular follow-ups, like those getting anti-amyloid therapies for Alzheimer's. Consistent, high-quality imaging is vital there.
Yeah, monitoring treatment, tracking progression.
Exactly. Making those crucial follow-up scans shorter, less burdensome, that makes compliance so much easier. It facilitates better longitudinal care.
That's a really powerful application. So what's next for DLMP RAGE or techniques like it?
Well, the immediate steps are clear. External validation in different hospitals, larger data sets, and comparing it directly to other acceleration methods like Wave KPMP RAGE to see how it truly stacks up. It's a fast-moving field.
Thank you for joining us on this Radiology Advances podcast. If you found this episode informative or have any other feedback, please rate, review, and subscribe. It helps more people discover the podcast and supports the broader conversation around innovation in imaging. You can read the full article and explore more great content on the journal website. This episode was generated with the help of AI, but all content was reviewed and verified by editor Dr. Nelson Gill from Massachusetts General Hospital for accuracy. Thanks for joining us.